We're going to turn now to Andrea Villanti, who's going to share some of her recent work on related to vaping in young people, and I think also maybe some research into the COVID implications for young people. Is that right?
That's right. Thank you for having me. I think this is a really nice sort of pair of talks because I'm going to be talking more about the ongoing research I do to identify those things in youth and in young adults that actually have protective effects related to mental health and substance use. So excited to talk with you both, Lauren and Sarah, too, about your program after this. So I'm going to give you a pretty quick whirlwind tour of some of the research that I've been doing as part of the PACE Vermont study, which stands for Policy and Communication Evaluation. I am an associate professor in the Department of Psychiatry. I'm a public health person, not a psychologist, and I do research largely on tobacco use in youth and young adults. But since coming to Vermont, I'm a Vermonter who left for college and graduate school and work and came back 20 years later. I have been working with the Vermont Department of Health on understanding how what we do at the population health level, policies that we put in place, mass media approaches, school-based and other programs, how that impacts substance use beliefs and behaviors in our teens and our young adults. So our PACE Vermont study is a partnership between UVM and the Department of Health. We received early funding from the Department of Health and the UVM Cancer Center to run a pilot study, which I'll talk about today. And then also I sort of shifted what I was planning to present after talking with Chris, and so have a bit more about sort of the research aspects of things that we've learned along the way. So we developed our PACE Vermont study to be a little bit different than what we currently had available to us in terms of surveillance efforts in the state. So right now we do population-wide surveillance as part of the Youth Risk Behavior Survey every 2 years. But what we have been coming up against is that new problems and products emerge rapidly, and we're not capturing them in real time. We have to wait for 2 years to figure out what's going on. So PACE is something a little different. We capture data quarterly in a cohort of about 1,000 youth and young adults. We're able to add and remove questions as things change in our environment. So if new policies come in or new communication activities. We complement existing data systems, so the national systems, the state level surveillance systems are still in place, but we are able to pivot and to capture information between those time points. We ask about things that are relevant to developing communication efforts for the state, including peer crowds, which have been identified as a really important way to target messaging to young people based on the values that they identify with, things like being academic or being social or being athletic or being country. So those are things that we're able to capture that are not currently available in our current data sources in the state. And then a really important piece of this is that we have this real-time feedback loop with the Department of Health. We're able to inform and support statewide efforts in real time. So I'll share a couple of examples of that coming up. So we ran a pilot study in 2019, again, to develop this cohort. Our first aim was to get a data system in place. We looked at how we could recruit people into our study, which we used online recruitment, we used community recruitment and participant referrals. And we brought everyone in to an online cohort study. When they signed up, they knew they were signing up for 3 surveys. They would be paid, well, we randomized the way that they would be paid, but they could earn up to $50 for participating in all 3 surveys. And so one of the other questions we had was, how could we keep people in a survey like this over time? And so we randomly assigned them to either a lottery payment, which they were entered into a lottery for $50 every week that we collected data. They could have received a guaranteed payment of $10 at each survey wave for completing, or they were assigned to whatever they preferred, either lottery or guaranteed. And then we were able to follow them over that 6-month follow-up period to figure out what worked best to keep them in the study. So our pilot data period went from spring to fall of 2019. We collected data spring, summer, and fall that year. And as we were recruiting people, we noticed how many people were coming in to complete our wave 1 surveys over time. And what we noticed was we had this huge bump in the number of completes over a couple of days. And so when we looked at these people, we noticed they were from IP addresses outside of Vermont or outside of the US. They had really unlikely email addresses for young people. Youth generally don't have an outlook.com email address. And they had inconsistent information across the things that we were collecting from them. We got their name in one place, we got contact information in another, we had address information from them as part of UVM payment forms. So we noticed there were inconsistencies across those things. So we had to develop a number of systems to ensure that we were getting valid responses. So we added automatic screening by location within our survey platform. We conducted consistency checks. We developed a protocol of conducting consistency checks between the age they reported and their date of birth, as well as state of residence and the location of their IP address. We added a CAPTCHA item into our screener to ensure that the respondents were humans, not bots. We conducted additional manual screening of study email addresses and phone numbers to see if they looked reasonable to us. And we compared information from the screening and payment forms to verify eligibility. So that was 2 years ago, and we've continued to do these recruitment efforts. We recruited last summer, and we're currently recruiting, and we've added a few more things, including Googling addresses of suspicious screening responses, where we found that a number of our participants happen to live at addresses that are listed on Zillow. So we have added that additional check to make sure that someone it shouldn't be that most of our participants who are being screened for our study are selling their home. So that's another piece that we've added in, and we've added in some additional manual checks over time. What we found was that generally our most efficient and cost-effective recruitment method was online advertising on Facebook and Instagram or on Google. You can see here how much we spent overall, and then for each of these different pieces. Generally, we had a cost per eligible enrolled participant of about $27. So we, for each participant that we got in that was an eligible participant, it cost us about $30 to get them in. So as I mentioned earlier, one of the pieces we're really interested in was what worked best for keeping people in. So how do we get people in? The best way that we got them in was through online ads on Facebook, Instagram, and Google. How did we keep them in? So you can see here, these are the 3 conditions. They were asked which of the following would they prefer. Would they rather get a $10 online gift card or be entered into a lottery? And you can see here, people were pretty generally evenly distributed across the guaranteed payment, the lottery payment, or the preferred option, which is whatever they responded to this question, they were given either the guaranteed or the lottery payment. And what you can see here is our enrollment flow through the study. You can see at wave 2, we had about 78% retention. And at wave 3, we had about 72% retention. That's pretty great for a fully online study. especially in young people. And what you can see here is there's really no difference across all three methods of paying people to keep them in. What we did see was that most participants wanted that guaranteed payment. They wanted the guaranteed $10. So that's what we've moved forward with in our study, is paying people a $10 online gift card for completing a survey. And if they complete all three, they get a bonus payment of $20, which equals $50 total. So here you can see the breakdown of our participants. We had about 480 youth aged 12 to 17 and about 1,037 young adults aged 18 to 25. The thing I just want to highlight here is we did have more females than males that participated. That's consistent with online research in general. Most of our sample was white, consistent with Vermont's population. We did have a higher percentage of young people identifying as LGBTQ plus than other samples. And we did have representation across the state, though we had a higher proportion of respondents from Chittenden County than from other counties. So what we did was we weighted these data by age and county. And the thing that I want to just highlight here is that this is our percentages of participants. You can see for Chittenden County, for example, 28% of our youth sample compared to 24.5% in the state overall. We did a little bit better with our weighted estimates in getting closer to what the distribution looked like across the state. And another great news piece of this was that our past month substance use estimates from our PACE study, which are in orange here, the estimate and the 95% confidence interval for the estimate in teens and in young adults, tracked pretty closely to state level estimates from the National Survey on Drug Use and Health from data collected in the same time point. So we have a fairly representative sample across the whole state. We use weights to improve representation and balance in comparison to the state estimates. And then we have these, our past 30-day substance use looks pretty similar. So that is all good news. So the way that we've used these data are a number of examples from rapid response type of projects. So I'll share a couple of those now. The nice thing is that we are, as I mentioned, tracking sort of in real time what's going on with youth and young adults. So in 2018, there was a change in marijuana possession policy in the state in July. In July of 2019, there were several e-cigarette related policies that went into effect related to tax on e-cigarettes and a ban on online e-cigarette sales. We also had the minimum age of tobacco sales increased from 18 to 21. We call that Tobacco 21. And then that actually became a federal policy in December of that year. And then, of course, the spring of 2020 was the onset of the COVID-19 pandemic. And you can see here waves 1, 2, and 3 of our data collection sort of straddled some of these important policies. And then 4 and 5 and 6, which is not on this line, happened post-COVID. So other things that were happening at the time that we were running our pilot, one of those was that there was the EVALI outbreak, e-cigarette and vaping associated lung injury epidemic that you may recall from the fall of 2019. And you can see here that, again, in response to that, there were state level actions related to banning flavored e-cigarettes. They did not actually do it at the federal level, but multiple states put bans in place on different products related to e-cigarettes, and there was a lot in the media at that time. So around that time, we submitted a grant and got funded from the National Institute on Drug Abuse to look at perceptions and problems associated with vaping in youth and young adults. And that funded 3 additional waves of data collection, 4, 5, and 6, 6 which we just completed last month. So that's what we have been looking at over the past year. We had waves 2 and 3 that sort of were in the early period of the EVALI outbreak, and then kind of right at the height of the EVALI outbreak. And what we saw over time from spring to fall was that generally the bars, which were ever use of electronic vapor products on the left or marijuana on the right, those continued to increase. So even over a 6-month period, we had about 5% of our youth trying electronic vapor products for the first time, and about 5% electronic vapor products or marijuana. And then about 9% of young adults trying over that time period, and about 4% trying marijuana over that time period. And past 30-day use of both products, which are the lines here for youth and young adults, were pretty flat. So we sort of expected that we would see some change in behavior in response to EVALI, but we really didn't see that happening over time. And interestingly, the EVALI outbreak was ultimately associated with substances in vaping cannabis products or marijuana products rather than standard e-cigarette products or nicotine vaping products. But we did see over time that there had been an increase in vaping, vaping marijuana or hash oil over this 6-month period. And then a large proportion of young people saying that they didn't know what was in the mist that they inhaled, about 10%. We also asked them whether they had tried to quit or cut down on their vaping in the past year. And what we saw was that about 61% of our electronic vapor product users or nicotine vapors had reported trying to quit or cut down, and only 1/4 of our marijuana users had tried to quit or cut down. And the reasons were somewhat similar across the 2 products. Health was a major concern, money and cost, and being free from addiction for our vaping product users. But you can see a much smaller number of people endorsing reasons for quitting or cutting down on marijuana. So in this period, the Department of Health launched between summer and fall, they launched UNHYPED, which was a vaping prevention campaign targeted to youth and young adults. And what we were able to demonstrate was that awareness of UNHYPED increased from the summer to fall as they ramped up their efforts. In addition to that, both in youth and young adults, we saw these increases. We're able to show that between summer and fall, one of the beliefs that was targeted by the campaign, which was related to a vape pod containing as much nicotine as an entire pack of cigarettes, that those beliefs actually shifted. So you can see the orange bars for yes being higher in the fall than in the summer in relationship to the campaign being in the field. And then we also were able to see that there was sort of a shift in perceptions of harm related to electronic vapor product use, with young people, young adults specifically perceiving greater risk, both in the moderate category and the great risk category of weekly vapor product use. Again, sort of demonstrating that the vaping prevention messaging was having the intended effect. So additionally, around the time that we got funded for our 4, 5, and 6 waves of data collection, COVID was happening. So we changed some of our items to focus on COVID. So we added 21 items on COVID-related stress. We included mental health screening, which we include in every wave, and past 30-day substance use, which we include in every wave. And what we were able to show is that there were some important effects on young people, that the changes in daily more than 60% reporting that had been difficult for them since the start of the COVID-19 pandemic, and also that the impact on school or work had been concerning to young people. Since we had data from the fall of 2019, we were able to compare with the fall of 2020, showing increases in both depressive symptoms and anxiety in youth and young adults as a result of COVID. And when we looked at past 30-day substance use, we really didn't see much of a change over time between the fall of 2019 and fall of 2020. But when we asked young people whether they had changed their behavior as a result of the COVID-19 pandemic, we saw that there were a number of people, if you look at these red bars, from about 24% up to 50% reporting that they had increased their use of a specific product since the start of the pandemic. So we were also able to look at the relationship between these stressors and overall COVID distress. We saw that each of these stressors that we asked about, the 21 items, were positively related with COVID distress, that COVID distress was related to depressive and anxiety symptoms, and that this relationship between depressive symptoms actually affected past 30-day cigarette and electronic vapor product use. So in addition, we've used this to launch other studies. So we ran a vape messaging trial last summer using our PACE brand and focusing on young adults. We were able to recruit participants and run a full trial of about 500 participants with 90% retention at 1 month follow-up, which is, again, really great. And these are some of the messages that we used in the trial. And these are our control messages. And we saw some important effects of the messages on perceived message effectiveness, effects on curiosity to vape and desire to cut down, showing our intervention messages were working better than our control messages. But we really didn't see any impact on outcomes that we measured, both right after exposure or at follow-up. So we're continuing to do a lot of work in this area, looking at patterns and predictors of vaping, nicotine, and cannabis. We're looking at the impact of mass media prevention on vaping-related harm perceptions and behaviors, looking at the impact of COVID-19 on youth and young adult mental health and substance use, and also looking forward to examining the impact of tobacco and cannabis policies in the state on beliefs and behaviors in young people. And I want to thank our fabulous PACE team. It's continued to grow, but here are a bunch of folks at UVM and Department of Health who've been involved. And we are currently recruiting if you know anyone who would be interested in participating.
Thank you, Andrea. Super interesting.